Good morning, everyone. Now, this is the second part of regenerative periodontal surgery. The first part, we mainly discussed about non-bone graft associated periodontal surgical procedures, mainly the methods by which we can remove the epithelium. We can avoid the epithelium by means of fatty tissue regeneration, then the use of root biomodification, use of growth factors, enamel matrix proteins, etc. In this part, basically, we are going to discuss about bone grafts. What are the different applications of bone graft? What are the types of bone graft? What are the properties of bone graft? How do you place the bone graft? All these things are going to be discussed in this part of, that is the second part of regenerative periodontal surgery. Now, based on how, where the origin of bone graft, you can classify bone grafts. And these bone grafts are classified into autografts, allografts, xenografts, and alloplasty. Now, when you are placing a bone graft in a patient and you obtain bone graft from the same patient, it is called as an autograft. When you obtain bone graft from another individual belonging to the same species, that is, suppose we are doing in humans, another human being, it is called as an allograft. Suppose we are taking bone graft from another species, say from cow, from pig, from horse, it is known as xenograft. And you have, the market is flooded with synthetic bone grafts, that is artificial bone grafts, that is known as alloplasty. So this is how you classify bone grafts. Now, when you place a bone graft in a defect, the graft behaves in different ways. And these are the properties of bone graft. It may have an osteogenesis property, it may be osteoinductive, or it may be osteoconductive. So what is osteogenesis? Now, when you place a bone graft within a defect, the cells within this graft will start forming new bone. So only one type of graft will satisfy this criteria. That is the graft which contains living bone cells. Which is that bone graft? It is the autogenous bone graft. Graft taken from the same individual. It contains living bone cells and it has the property of osteogenesis. Now suppose when you place a bone graft, this graft will contain certain proteins or mediators or factors which can activate the neighboring cells to differentiate into osteoblast and produce bone. That is, it will induce the neighboring cells to differentiate into osteoblast to produce bone. Such property is known as osteoinduction. So this property is there for bone grafts which mainly has got mediators called as BMPs or bone morphogenetic protein. The alloplast, that is a decalcified freeze-dried bone allograft, belongs to this category of osteoinduction. Then most of the bone graft that is available in the market belongs to this category, which is known as osteoconduction. Now, when you look at this type of bone graft, you can see in the microscope or at high resolution, you will find that it will be like honeycomb. It has got lots of pores inside that. Okay, so what happens when you place this bone graft? From the neighboring area, from the blood clot, the osteoblast will migrate into this bone graft within this pores of the bone graft, and it will stay there and it will start forming bone there. And as and when new bone is being formed, this scaffold, this matrix slowly gets resolved and the whole thing gets conducted into bone. This property is known as osteoconduction. So most of the bone graft that is available in the market belongs to this category of osteoconduction. And you have one more property that is described in the latest Cadenza edition, that's the 12th edition of Cadenza, known as osteoneutral, where this bone graft just stays like that over a period of time. It's a neutral. Now, what are the considerations that govern this? How do you select a graft when you see a defect? One, the graft should be biologically acceptable to the patient. When you place the bone graft within the site, it should predictably form bone in Is it clinically feasible to do a bone graft in that particular situation? Is it clinically feasible to get bone from extraoral site? Are there any operative hazards associated with it? When you place this bone graft, will there be any post-operative sequelae? Will the patient accept it? As I told you before, you take graft from different species. Suppose you're taking graft from a cow. Now, certain religious people won't allow that. So you have to inform the patient beforehand, telling that the origin of this bone graft is this. Are you acceptable? Or should we look for another alternative bone graft? These are the considerations that cover the selection of a bone graft. Now, first we'll discuss about the first type of bone graft, that is autogenous bone. That is the bone graft from the same individual. Now, it can be classified into bone from intraoral sites or from extraoral sites. First, we'll discuss about intraoral sites. Where are the intraoral sites from which you can get bone graft? One is healing extraction bone. That is a very good site. There is a recent extraction from that site. If there is an edentulous ridge, very good. You can refine. You can just get lots of bone from there. Any part of the jaw, especially the symphysis, the posterior mandible, you can refine it. Then the bone that is removed during osteectomy or osteoplasty. Maxillary tuberosity is a good area from which you can get intraoral bone. So these are the different areas by which you can get bone. And this intraoral bone itself, you can actually, this bone can be subjected to a little bit of manipulation so that you can place that defect easily. You can increase the property of bone graft. One is osseous coagulum. Now it is bone dust and blood. So basically you are crushing the bone into small particles so that you are increasing the surface area so that you have more interaction of cellular and vascular elements. This is known as osseous coagulum. The second thing is known as bone blend. So what you do is, similar to your trituration that you do while doing amalgam restorations, you take this bone, large pieces of bone, and it's triturated in a capsule to a workable plastic consistency so that you can adapt it to that particular defect. And you will have marrow bone you can obtain from different areas, tuberosity, edentulous areas. And this bone is usually harvested using different types of curettes, chisels, or refined. I'll just show you. Now, this is a back action. This is a chisel by which we just scrape this. Now, when you scrape this, you get bone like this. And this is a refine. What is a refine? You have a burr like this. Now, the inside part is hollow. So, into a edentulous area or wherever you find bone, just drill it so that the bone gets collected within this. That you can go to the bone graft. These are refine. You can use multiple holes in different areas. Then, whenever there is a defect associated with an edentulous area, suppose you don't have an edentulous area like this, usually the food will migrate to the city and it will have a defect like this. So you can do a procedure which is known as bone scraping. So you just make a cut on the bone like this, and then with a chisel or appropriate instrument, you just push this bone without breaking the basal bone from the basal bone. You can manipulate the bone. It's very easy seeing in this radiograph, in this picture, but mind you, it's very difficult doing this clinically. So this is known as bone sewaging. Now we are going to look at bone from extraoral sites. What are the different areas from which you can get bone extraorally? Now, extraorally, suppose in some cases, not mainly for periodontal defect, but mainly, when you do for probably reconstruction. So after the cancer surgery, okay, after trauma, you need a large amount of them. In that situation, you take bone from tibia or the iliac crest. Now, our dental surgeons or even maxillofacial surgeons trained to obtain such large amount of bone from external? No, they are not trained. So you need an anesthetist, you need a theater setting, you need a surgeon. So the cost and everything, then there's morbidity to the patient, everything is associated. A lot of disadvantages for bone from external sites. One is there may be a chance of post-operative infection. This bone that is harvested can get exfoliated and sequestrated. The intraoral bone heals at a particular rate. The extraoral bone heals at a different rate. So there is varying rates of healing. And when you place such bone adjacent to uh, a root, there is chance of root resorption, recurrence of defect. The cost of the whole procedure is increased. And as I told you before, the procuring the material and mobbing to the patient. So there are a lot of disadvantages. So only in such situations where, in spite of all these disadvantages, you need this large amount of bone where it's going to be advantageous to the patient. Such situations you take bone from external sites. Now, allograft. I told you, allograft is taken from individuals from the same species, from a different individual. Usually, when a person dies, immediately, probably within 12 hours of death, you take bone. Of course, you have to take, patient should have given, the person should have given consent, or his relative should give consent. It's usually done in tissue banks. So you take it, take the bone, cortical bone is obtained 12 hours after that. Within 12 hours, then it goes through a lot of process. Because, suppose even if you have to use someone else, suppose you have even blood when you transfuse, you have to look at a lot of things, blood grouping, antigenicity, all this. Similarly, you have to remove all the antigenicity associated with this bone graft in a different individual. So this bone graft will go through a lot of process. So first it is defatted, it is cut in pieces, it's washed in absolute alcohol, then it's defrozen, then later it's demineralized, then it's ground, sieved to desired particle size, freeze-dried, and packed in glass bags. So, sorry for the break. I had some technical problems in between. So this material is then ground and sieved to the desired particle size. It's freeze dried and packed in glass vials. So this bone graft that is obtained from a different individual goes to lot of different steps so that it can be used on a different individual. Now, when you look at allografts, you can classify based whether it is decalcified or not. One is freeze-dried bone allograft, where the bone graft is not decalcified. The second is where it is decalcified. Then it's known as DFTPA. The decalcification, what it does is exposes the BMPs. So that makes the bone osteo intact. So that is a basic idea of decalcification. Then you have different types of bone grafts that are obtained from uh, different species. Bovine means from cattle, from cow. Equine from horse. Porcine from pork. So, but basically, all these things have got religious implications. So you have to priorly inform the patient, tell him that this is the bone graft. Are you comfortable with it? Get a consent, written consent. Then only prescribe bone grafts, xenografts. graft is non-bone bone graft material. It is not bone. Now, all these, right, it may be autologous bone, that is the same person or different person or from an animal. These are non-bone graft materials. But these are, all these materials have been, right, they are not bone, but sclera, dura, cartilage, cement, tendon, plaster Paris, hard tissue replacement polymer, HDR polymer, then ceramics, then natural, oral derived hydroxide. These are all non-bone graft materials that has been tried. Now, commonly when you look at alloplast, that is, we are discussing about synthetic grafts, you have mainly the calcium phosphate biomaterials, and there are two types of calcium phosphate biomaterials. One is the hydroxyapatite. That is the most commonly used type of bone graft. You can say it's commonly available. It's the most cheap type of bone graft. But the problem with hydroxyapatite is it is not bioresorbable. So probably you do a bone graft, and later on, probably about 2 years, you open up that site, you may find most of these bone grafts like that. It is just as an inert material, it's dead. Then tricalcium phosphate, it is partially bioresorbable. It's also fast also tricalcium. So, but when you look at the property of this material, they are osteoconductive and they are well tolerated by the tissues. That is why it is being used in large quantities, cheaper also. Again, you have type of material which is known as bioactive glass, which contains sodium and calcium salts, phosphates, and silicon oxide. And it is available by the names of PerioGlass and BioGran. Bioactive glass, PerioGlass, and BioGran. And this particular graft has got a peculiar property. That is, when it comes into contact with tissue fluid surface, the surface becomes coated with hydrocarbonate apatite and incorporates organic ground proteins like chondroitin sulfate, glycosaminoglycans, and like osteoblast that rapidly form bone. So what they say is, immediately gets attached to the root surface when you place this type of ground graft. And so when you use a bioactive glass, probably you don't need a GTR membrane. That is what the manufacturers of this type of bone graft claim. Now, these are the steps in which you can place a bone graft. Suppose you see a defect like this after you open the graft in the granulated area. Now, what you can do is, into this area, you can fill this bone graft. So, how do you fill this? You can use this bone. You take the particulate bone graft, whatever type of bone graft. You can mix it with either the patient's own blood or a little bit of saline, and then you just place it, condense it. But this whole area is defect, but there is no point in this placing the graft more than the remaining bone. Now, if you put it here, the whole area is avascular. On the other side, you have the avascular. You don't have any vascular structures here. So until you have some amount of remaining bone with an angular defect, till that area you place the bone. There is no need of overfilling the defect. Then you switch. Similarly, you can see a deep defect here that is being filled with bone graft, and these are the preoperative photographs of buccal and the lingual side, and you can see the defects like the angular defects can be seen. So this is the defects you can see after exposing the flap after doing the regeneration, and these small defects are being filled with this bone graft. And this is the post-operative, the preoperative, and this is the post-operative. And to summarize the reconstructive surgical technique, you can see that I discussed about a lot of techniques. I discussed about curettage. I discussed about guided tissue regeneration, use of growth factors, wound conditioning, bone grafts, and all those things. But depending upon the techniques, you can choose which all techniques is needed. Okay. Suppose if you have there are certain factors which guide which techniques to use. Okay. One is what is the dimension and the morphology of the defect. The deeper the defect, the better results you get. You won't feel you get. Whether there is a number of walls, whether it's 3-wall defect or a 2-wall defect or a 1-wall defect. If you have a 3-wall defect, is always the prognosis is much better than a 2-wall defect. Again, a 2-wall defect prognosis is much better than a single-wall defect. amount of root exposed and the ability to flat coverage. So how much amount of soft tissue is there so that it can cover the bone graft that you are going to place. That is also something that you have to look for before you do which technique you are going to decide. And the angle of the defect to the lamina of the bone. The smaller the angle, the better the success. So if you have a small angle, so small angle means you have an angular, a deep angular defect in such cases. And larger angle means you have more of a horizontal type of defect. It's very difficult to regenerate. So clinical decision tree has been put forward by a person known as From. According to him, for a deep well contaminated. So this is a deep defect, well contaminated, easier defect. So you can use an enamel matrix protein alone with a coronally advanced platform. That is what they say. A deep, and we are talking about isolated defect. But if it's a moderate and a deep non-contaminated defect, again, you can use enamel matrix protein. You can use bone graft and place a coronally advanced platform. But it's almost the horizontal type of defect where the regeneration is, the probability of regeneration is least. To start defect, you can combine all of this. You place enamel matrix protein, place a bone graft, then you place a barrier membrane, Along with that, you only advance the platform. All these procedures. Okay. As and when the prognosis become worse, you try to incorporate more of these techniques. When you're incorporating more of these techniques or more of these factors, the cost of the patient increases. That is the problem. Because you can incorporate all these in each and every patient. So that is the end of regenerative periodontal surgery. Thank you. Thank you all for listening.